Okay, so the last video we looked at assessing the emergency room patient, and namely forming a differential diagnosis and then your primary survey and your initial actions. Now we're going to get into the history and physical, that is the secondary survey. The history and the physical. So here I am again. I've got my IV, my O2, and my monitor suffering from my chest pain, and here you are at the bedside, armed with your differential diagnosis. So in the emergency room, it's very important that we take a focused history and physical. The emergency department is a busy place, and there's always patients coming in, some of them sick, so we don't have all the time in the world to spend in a detailed history and physical. So our goal is to be concise yet thorough enough with all the life-threatening diagnoses, namely those things that we put in our differential diagnosis. And here's a method that many of us use to take that focus history. The first thing I'll do is I'll let the patient speak for 2 minutes, uninterrupted. This doesn't sound like a lot of time, but it actually is. Most physicians will interrupt a patient within the first 23 seconds of their starting talking. So, what brought you to the emergency room today? And they say chest pain? Okay, tell me about that. And then I let them talk for 2 minutes. I'd say about 85% of the time you're going to get your answer in that 2 minutes. Occasionally you'll get someone who isn't too talkative, or the converse, somebody who's just a chatty Cathy, and you might need to reel them in, but let them go for 2 minutes. But after that, that's when I take the reins. And then the next step is to get a good description of the pain or chief complaint that brought him in. And there's probably 100 mnemonics you could use to describe a chief complaint. I'm going to use one that was given to me by Dr. Jack Wu. And Dr. Wu wants you to get a cold read on this patient's chief complaint. And this stands for character, onset, location, duration, radiation, exacerbating factors, and alleviating factors. And finally, what's different today about this? If someone comes in with belly pain that's been there for 2 weeks, ask them, what changed about the pain today that prompted you to come today? What's different about it today? A lot of times, you're going to get some very important information from that question. Now, this description, having a very good description, helps us focus on our differential diagnosis and decide which things are more and less likely. Now, after you get your cold read, start asking questions which are specific to your differential. This is also called the pertinent positives and negatives. The idea here is basically that you want to convince yourself that your patient is or is not suffering from these things in your differential. So let's take the example of our chest pain patient here. So questions I might ask for acute coronary syndrome would be, is it a pressure type pain? Does it radiate anywhere? Do you get sweaty with it? Nausea? Is it made worse with exertion? Do you have a family history of heart disease? Do you use cocaine? And so forth. For PE, I would ask things such as, have you ever had a PE or a DVT before? Have you ever had cancer? Have you had any recent surgery or recent travel? And so on. And thoracic aortic dissection, you might ask, is this a tearing type pain? Is it between the scapula? Does it radiate down your back? Are you having pain above and below the diaphragm? You could ask questions regarding connective tissue disorders. Tension pneumothorax, you could ask for trauma. And esophageal rupture, you might ask for any history of vomiting or belly pain. So of those questions, the ones to which they answered yes would be a pertinent positive, and the ones to which they answered no would be a pertinent negative. Next, you're going to get your standard past history, so your past medical, past surgical, meds, allergies, social history, its family history, etc. And finally, your review of systems. The review of systems is a giant catch-all where you can ask about all the other seemingly unrelated complaints that the patient might have. Now, the review of systems is actually fairly important for billing purposes. Insurance companies grade charts based on different levels, with some being lower acuity and others being higher acuity. And in order to get that higher acuity rating, you want to have more systems reviewed in the review of systems. So for a guy coming in with a twisted ankle, you don't need so many. So maybe you have 3, 4, 5 systems. Pulmonary, such as do you have a cough or any trouble breathing? GI, are you having any nausea or vomiting? GU, are you having any trouble urinating? Neuro, are you having any headaches? But for the patient coming in with an MI, you'll want to have more systems reviewed. For the highest level charts, they're going to look for 11 systems reviewed. Now, of course, in a septic patient, they're not going to be talking too much, so you might just have to notate that the review of systems was not possible because of the acuity of the patient. Maybe they were intubated or demented or altered mental status. So the review of systems is important for billing, but it's also a good place for you to put all those complaints that you're not really sure that they're related to the differential, but you wanted to bring them up to be complete. So now you're done with the history, a focused history, and it's time for a focused physical. And again, remember that this is guided by your differential diagnosis. You're going to want to look on physical exam for things that are important for acute coronary syndrome, for pulmonary embolus, for thoracic aortic dissection, tension pneumothorax, and esophageal rupture. So you might look for signs of pulmonary edema or CHF in the patient with a heart attack. A PE may have a swollen leg. They may have a DVT, which is the cause of this, thoracic aortic dissection. They may look sweaty and diaphoretic and hypotensive. Tension pneumothorax, you might look for JVD or decreased breath sounds on one side or tracheal deviation. And esophageal rupture, they may be vomiting. You might hear some crepitance in the chest. So you can see now how your exam is even focused by your differential. And that completes your secondary survey. You have a history of physical, and you learn how to do a focused history and a focused physical. And once this is done, the next thing you're going to want to do is to refine your differential further, and that is to assign pretest probabilities to all the diagnoses in your differential. So based on your history and physical, what is the likelihood that you think the patient is suffering from an acute coronary syndrome? Is it no, low, medium, or high? Similarly, what about PE? Maybe you rank that low. Thoracic dissection, maybe we'll call that medium. Thoracic tension pneumothorax, we'll say, no, he doesn't have that. Esophageal rupture, no, I don't think it's that. It's important to set these probabilities because the next step, which is where we're ordering tests, really is based on how likely you think these differentials are. For example, if you have a 19-year-old coming in with chest pain while eating a bag of spicy hot Cheetos, you might think their risk for acute coronary syndrome is pretty darn low, and you might say, I'm going to do nothing, or maybe I'm going to do an EKG. But let's say you got a 72-year-old patient coming in with chest pain who's got a history of coronary artery disease and is also eating a bag of spicy hot Cheetos. You might say, well, my pretest probability is medium for this patient, so I'm going to do an EKG and I'm going to do a troponin and I'm going to admit this patient for a stress test. So in order to decide which tests you want to order and also to interpret those tests, you need to have an idea of what your pretest probability is. Alright, so let's go on to ordering the tests now. And let's say these are the probabilities I have for my patient. So at this point, how am I going to prove to myself that my patient does or does not have an acute coronary syndrome? Well, I want to get an EKG, I'm going to get a troponin, and I'm going to admit this patient because my suspicion is so high, I don't feel safe with them going home. And if everything rules out, they can get a stress test or some other provocative testing in the morning to make sure that they're not having unstable angina. PE, I thought it was low, so I'm going to go with a D-dimer. And if that's negative, I'm done. If that's positive, well, I'll decide what I need to do from there. Thoracic aortic dissection, I said it was medium. I'm going to start with a chest x-ray and look at the mediastinum on that. If that's wide, I'll consider a CT or an ultrasound. If not, I'll decide from there. Tension pneumothorax, I said it's not that. No further testing required. An esophageal rupture, no further testing required. So now you can see here, there's a reason why I'm ordering everything that I am. I might also order a CBC just to look for anemia. That could cause ischemia. and a CMP because I'm going to look at the creatinine. If I want to order a CT of the chest, I'm going to need that creatinine. And that's it. That's the initial workup of your emergency room patient. We started with forming a differential. We do that even before we see the patient. The first thing we do when we look at the patient is assess their primary survey and perform any initial actions that we need to do. A secondary survey, which is a focus history and a focus physical. When we get those things completed, we're going to assign pre-test probabilities and finally diagnostic testing. So the next video, we'll talk about how to present a patient in a concise way and hopefully under 3 minutes.